Thank you for coming. I'm excited to be here to talk about this topic. I'm just going to start by talking about something I think we are all already aware of, which is precision medicine. So basically, as a medical community, I think we're generally looking towards moving from sort of a one-size-fits-all model of medicine to a precision model. So we're looking to take personal, typically multimodal data to predict best treatment. The idea is that eventually this will result in better efficacy, fewer side effects, lower cost. That is not going to happen immediately, but the hope is that down the road we'll get there. So let's think about then what the role of XR in this process is going to be. So how are we going to get there? I think we can use XR in a number of ways. So first, we can use it to evaluate some of these individual characteristics that we hope to use to inform our precision medicine models. So we can do things like simulate an emotionally evocative situation and measure physiology and response. We can do things, we've talked about this a lot at this meeting, like use AR-based data to evaluate walking habits, to evaluate the built environment, and so on and so forth. An area we're all very, very familiar with, I think, is to add to our armament of treatments that we can use by adding XR therapeutics. We, of course, also envision XR to train and educate patients and providers about proposed precision treatment regimens, so on and so forth. And finally, to think about how to evaluate our outcomes. So thinking about, say, VR neurocognitive testing. So in my view, XR fits into absolutely every element of this pipeline. All right, how do we get there? So I think this is better considered from sort of a person-centered model, so we're going to look at it this way. We can think about SAM. So SAM obviously comes with their unique set of multimodal data. In our world, of course, SAM has their own headset, SAM has sensors. We can think about watches and other things. SAM, of course, is embedded in a larger system. So we'll think mostly today about the healthcare system, but I would be remiss not to mention the larger socio-political system that SAM lives in and that the healthcare system operates in. So this embedding is critical, this connection, but we also need to consider SAM's data. I'm going to consider this data as one big data, but we know that this is not really how it's going to look, at least initially. We're also going to have to think about the models, the algorithms we're going to use to understand the data. So already we see where our XR model fits in. We have our multimodal data. We have our patient-centered XR. So here we're going to think about our treatments. We're going to think about patient education. We'll think about assessment of outcomes. I also think if we do this carefully and ethically, there's also room to think about how non-medical use of XR and the data that we get there, such as longitudinal assessment of cognitive outcomes, gait maybe, things like that, how we can harness that to feed back into the models. And I also want to note that this arrow kind of feeds both ways, right? So, not only is SAM's data going to feed into the model, but the model, of course, comes back and it feeds the XR experiences that SAM is going to have. Within our healthcare system, we envision, of course, education and training, precision procedures, communication with patients, communication with colleagues, and again, of course, arrow goes both ways. SAM's data informs XR models. XR models can inform what's going on in SAM's EMR, for example. Now, we mostly don't deal with raw data. We would be in trouble if we were. So we're going to rely on visualizations, extractions, and all kinds of different forms of data, like dashboards, EMRs, static reports. And we also, of course, as we've talked a lot about at this meeting, envision the potential for digital twins, so digital human twins, which I think we're pretty likely to engage in some contexts immersively. So here we may do communication, decision-making, and we may be able to configure these digital twins to help us encourage preventative behavior. All right, so we're going to talk now about the piece that I think was missing from the other system, which is sort of the whole systemic implementation piece. This is really where I'm going to focus today because I think it's actually an area where we don't focus quite enough. So in thinking about implementation research, what we're really doing is developing our best practices and our approaches for the system and seeing how the data, the XR system, all of the pieces perform together in the real-world context. So this will help us answer questions like, will the patient data be used as we anticipate? What do patients and providers need to know to prepare for these kinds of models? And so on. So here's where we really need our evidence-based approaches to get us from our current state to a holistic precision medicine approach that we would like to see in the future. So I think XR is really important here, but I don't think we think about that often enough. Why? Why do we need to look at this area now, right? So the state of health tech, and especially all the things that drive precision medicine, is such that oftentimes when we are developing new tech, new procedures, we are integrating them into medical situations really, really quickly. So often the tech development is happening alongside the implementation, and essentially we're building our car as we're driving it. Now, implementation and communication happens last in this pipeline most of the time. So by the time we're ready to do this research, we're already seeing these things in clinic. It's too late to be guiding its integration in a way that's most helpful, most ethical, most useful, and so on. All right, how do we fix this? How do we go ahead and do research on a thing that is not clinically real yet? Say it together with me. The answer is simulation, right? We wouldn't be here if it weren't. All right, so we're going to talk about a case study today. I come from the Genomics Institute, so I am going to talk about genomics. We're going to talk about this case study of a new technology called polygenic risk scores. So just so we are all on the same page, this is a new development in genomics. It's essentially a statistical approach. It's a machine learning model, often a black box machine learning model, where we're taking the presence or absence of many, many genomic variants. We don't necessarily know how they're contributing, but we're taking this model and we're identifying those people at the tails of the normal curve. So those ones in red there who are really at the highest risk of a condition. And this can be really, really impactful. This can be a lot of increased risk if you are found to be in the tails here. So these polygenic risk scores are really a major priority at NIH. Elsewhere, this is one of the big ways we think that genomics can contribute to precision medicine. And in my mind, most important here is that it's really able to address some of these common complex diseases and conditions that we have not been able to address with genomics in the past. So it tells us a lot about risk for things like coronary heart disease, diabetes, and so on. So as I mentioned, the technology is often being used as it's being developed, right? So this technology has emerged relatively recently, really in the past 5 to 7 years or so. Almost immediately, it became available in a direct-to-consumer type format. So you could send your DNA away, maybe to 23andMe or one of its competitors, and get these kinds of scores. What did we do with these scores? We don't know, but you could get them. There's been scattered clinical implementation as well, and this implementation is starting to ramp up more and more. What don't we know? What we don't know is how should these be used? What is the clinical influence? What happens when these polygenic scores end up in the clinic? What does a physician do with them? How does a patient understand them? We have no idea. They're coming to clinic. What could go wrong? My favorite question. All right, so let's ask this in the context of our precision medicine framework here. So we see addition of these genomic variants, the polygenic scores, that can come from outside the healthcare system or inside the healthcare system. We see these new algorithms and predictive reports. It generates a risk report. Right now, those are generally static, kind of documents, PDFs, if you will. And then we see how they filter in and influence as they're provided to patients and providers. From an implementation standpoint, what do we really care about at the end of the day? We care about how this information is going to impact Sam's care and whether we can intervene now to make sure it impacts Sam's care in an appropriate way. So what I'm going to do, I'm going to go through a couple quick research examples where we looked at this and talk about how we use simulation to do this. So I want to highlight my amazing collaborators, Vince Baum and Brittany Hollister, who worked tirelessly on this project with me. Our specific research questions are here. They're really, really broad. They're basically, what will providers do with these? At the time we were starting this study, which pre-pandemic, this was mostly coming in a direct-to-consumer kind of format, so that's what we looked at. We looked at how the introduction of polygenic scores would influence clinicians' behavior in a clinical setting. And importantly, we looked at how this technology would be used, whether it would be applied similarly across all patients or whether patient characteristics might influence how the scores were applied and used. Because oftentimes, although we don't intend it, these new technologies tend to introduce new health disparities as opposed to addressing existing ones. Okay, so how did we do this with VR? So we created a VR clinical encounter. In this case, we were using med students as our participants, and these med students interacted with a virtual patient in a VR environment, as you can kind of see here, how we ran this. So this is going to replicate elements of the healthcare encounter and kind of the elements we expect to see in the future of care when polygenic risk scores are a little bit more routinely used. So because we want to understand the influence of polygenic scores, and we want to do an experiment, we give them to some participants, and other participants get a control, and they do not see these polygenic scores, and then we have them interact with a virtual patient in a clinical encounter. We, as you can see, vary some of the appearance characteristics of the patient to see how the polygenic scores are used. And then, very importantly for our purposes, we make sure that absolutely everything else in the scenario is identical. Okay, so aside from these two things, everything else has to be the same. This is really critical, so I'll put some stars here. Okay, so unlike in real-world clinical research, right, in the XR simulation, we have the power to do causal inference. This gives us the ability to know that if we see differences in outcomes between these four groups, we know where these outcomes came from, and we can say that it was the scores or it was the patient characteristics that caused this. This is not something we can do in real clinical settings, so it's kind of one of these superpowers of VR that people like to talk about. All right, so the study kicked off in 2019. At the time, for us, the best approach was a scripted encounter. I'll talk a little bit more about this, but it's essentially a scaffolded turn-taking interaction. It looked like this. So the participant would review the electronic medical record, introduce themselves, and the patient would sort of lay out the clinical case while the medical student could respond and make recommendations and so on. The clinical case had to do with unexplained tiredness, some knee pain, and then she was also really interested in these direct-to-consumer genetic tests that she received, and she wants to know what it all means. So, very simple interaction, very simple graphics, as you saw. All right, so we're at this meeting, and we're coming to a day and age where we are seeing photorealistic, fully AI-based interactions with characters. So sometimes we forget, and I really want to highlight, that sometimes these really simple approaches can get us where we need to be even better than the new technologies. So why does a simple encounter like this work for our purposes? First, we have the old stand by the media equation. This has been around for a really long time, but the idea absolutely still holds in VR. And this is the idea that when people interact with media, including VR simulations, they tend to respond to people and places as if they were real. They have interactions that feel social, they feel natural. So basically what this allows us to do is make our virtual humans into sort of a blank canvas or sort of a non-scientific Rorschach test, right? Because when people have limited information in a scenario, they tend to sort of fill in the blanks and make decisions based on their own beliefs and attitudes and stereotypes. And when they are presented with a clinical encounter in the future that is unfamiliar, uncertain, these are the exact same stereotypes and heuristics that are going to fill in those blanks and what they will rely on. All right, so let's look back to our study. So what we did after the interaction was one of the things we asked participants was, did you use this polygenic risk score information? In general, most of our participants said, yes, it was useful, I used it. And then we said, okay, well, did you use it to make decisions about the patient's care? The important thing that is in this clinical scenario, that would have not been an appropriate thing to do. There wasn't really much in the polygenic scores that pertained to the patient's concerns and her medical situation. So only 8% said, yes, I would do this. In fact, when you look at the data and we look at what was actually recommended, we see wide variability, which suggests that indeed they were using the polygenic scores. And we're going to zoom in on diabetes for just a second, and you can see that in the case where polygenic scores were given and the patient was presented as Black, far, far more likely to recommend further diabetes evaluation. We also looked at a lot of interpersonal things, in terms of stereotyping, negative attitudes about the patient, looked at nonverbal behavior. We saw differences here as well. So what this says to us is that some of this information is being used clinically in a way that isn't really clinically appropriate. And so we probably need to think about doing something about this as it's entering clinic. So what does this mean to us? So first, we need to think about training and educational materials about the polygenic scores that addresses these issues. We need to think about what kind of information, how are we presenting the scores? What kind of information does it come with? And then, of course, that we really need to think about sociodemographics as we are creating these things and as we are thinking about application. So I'm going to talk about just another study we are actually in the middle of running right now. I actually think we have a participant right this minute. So this is ongoing. Okay, so this is sort of the next step. It's actually the exact same research questions, a little bit of a difference in the clinical case and the context. So what's really changed, and I'll also highlight my collaborators, Renee Sterling and Rob Wowley, who've been wonderful in this project. So in the time between the first study and the second study, telemedicine has become very much mainstream, which gave us a great opportunity to take our virtual patients, and rather than bringing participants into a virtual clinic, to do a virtual telemedicine visit instead. Pros and cons, of course. So the context is natural, because it's the new natural, right? It's less immersive. We lose some of what we get in the sort of virtual tracking, the nonverbals, all that, but we do also get some information about the EMR. We're also doing recordings that I think we'll be able to assess later. Okay, same idea. So in this case, we're looking at typical versus high-risk polygenic risk scores. A little different, but I think what we're seeing is going to be coming to clinic. So these are much more clinically focused polygenic scores as opposed to direct-to-consumer. We also were really interested in this patient characteristic aspect. So we looked at many more variations to look at that a little bit more fully. And again, of course, everything is identical. So this is sort of the participant view. Here we are using practicing providers. Our plan is to collect 200 practicing providers who are in this simulation. This virtual patient is a little more interactive than our last one, but we still opted to use a Wizard of Oz approach as opposed to an AI approach. So this is a research assistant who is choosing the way that this patient is going to respond to the clinician on the other end. Okay, so why are we not using AI? Well, if AI starts to introduce differences between scenarios, which it absolutely will, right, based on what the provider is saying, then that disrupts this causal inference that we're getting from using VR in the first place. So right at the time when we were doing this study, and I think it may still be true, we didn't have an AI model that we really trusted to be able to keep this kind of standardization between conditions. We are certainly using AI in other places. We are not AI phobic. I'm just showing you a quick example here of a study I'm doing with my colleagues Laura Cayley and Reagan Bishop, where we're training patients to disseminate cancer risk information about genetics with their family and help them practice these conversations. And here AI is absolutely the way to go, and this is going to work really well. So when the study is finished, can't tell you right now what's going to happen, but when it's finished, we're hoping that we can provide information that's going to help us with polygenic score use, help us mitigate some of these unintended influences, develop unbiased EHR reports to guide algorithms in use in the future. And as we're moving away from just using genomics and moving more towards these more multimodal models, think about ways we can integrate some of this information into the multimodal models to mitigate issues in the way we're using the scores. So as I mentioned, this work is just one of the many, many ways I think XR can contribute to the massive amount of research that we still need to do to get to this sort of systemic precision medicine model. Here we're going to try to connect several pieces of the larger system. So there's a lot of work that we're also doing in this area that isn't about the implementation piece. Well, some of it is about the patient response. Okay, that's implementation. But how is the patient going to respond to this? Some of it is about predicting the efficacy of XR therapy from some of the data we can collect. Looking at how we can get data to feed into the models from XR use, both clinical and non-clinical. Using XR for training and education to help that precision medicine implementation along. Looking at, we're just starting this now to look at digital twin design in ways that can actually help to do healthcare communication, risk prediction, and health behavior modification for the future. And then, of course, there's a lot more to do. I'm hoping that I've convinced some of you that maybe this is an area you may want to work on because it's going to take more than a village. It's going to take all of us working together. So that's all I have. I want to really thank all of my collaborators and my team who have made this work possible. I'm happy to take questions, and I also put my email address on here, so if you want the slides or you want to reach out, feel free. And if anyone has questions, I'm happy to take them, even the hard ones.
I wasn't going to ask a question. This is amazing. There's a lot of potential for this, and I really look forward to working with you on some of that.
Thank you. Me too.
Hi, Susan Kirsch from the VA. I know we know each other, but I'm going to ask this in front of everyone. So I'm a primary care doctor, and I've been to a lot of outside of VA meetings and understand that what you're talking about is absolutely where the puck is going. My question is, we have a lot of different pieces. We have a digital twin program, we have simulation, we have immersive, we have the Million Veteran Program, which is our genetic data. And so I'm wondering how far into the future that you think, or what would you recommend even to pull pieces together to really operationalize some of this work? And I'm thinking clinically about informatics folks. Could they play a role in and immersive to train them in how to really move to where the puck is going?
Yeah, I mean,
It was amazing.
Oh, thank you. I think there are, as you say, so many pieces to the model. I think the informatics folks are going to be probably the most critical because these multimodal data models are very difficult. AI is not up to the task, I don't think quite yet, to do this across multiple diseases, digital twins, across multiple conditions for a single person yet. I think the next step is really going to be taking some conditions, taking some set of treatments and trying to sort of work on it there. My hope is that we will get to these larger models and we will be able to look at how different conditions and treatments intersect with one another, but that obviously becomes more and more complicated. So I think we start simple, but I just want to make sure that we don't forget about this communication piece because we tend to focus on the models, we tend to focus on what goes into the EMR, what does the clinician see, but we have to make sure the clinician is using that appropriately and we have to make sure the patient understands. So, I'm a communications person, and so that's really the piece that I'm focusing on. I don't want to make a hazard about how long it's going to take. We are starting. I'm hoping, it'll be not too long, but I think we have to start on the little pieces first. Yeah.
Hi, I'm Hari from VML Health. I'm wondering if you're incorporating any sort of sentiment analysis when you do these assessments, because you have an opportunity to get both voice and facial recognition as you do these research studies.
Yes, so we are. So as of now, we just collect the data. And in the past, what we've done is hand coding. So I've had research assistants sit and basically do human sentiment analysis, if you will. But now, is essentially what we're doing is we're collecting the data because we know when this study is done, in 6, 9, 12 months, the technology will have already changed. So we're collecting the data and plan to use whatever is sort of, the most evidence-based best approach when we get there. But I'm not going to, make that decision now, but we absolutely do plan to do that.
Aubrey Schick, ex-FDA. So I super appreciate this, and I love your what could go wrong, and I think it's you mentioned training and that opportunity, and the state of what is. Well, I'll just say digital literacy is changing very, very quickly. And I know, at least in FDA's generative AI public meetings, one of the things that American College of Radiology brought forward was how important it was to train specific providers on the mistakes and the errors of that specific system. And what I'm seeing here is that there's this tremendous opportunity for training of the specific types of errors. And I was wondering kind of what your thoughts on that, where you think the most important kind of opportunity is, recognizing that training is a potential mitigation that could be appropriate as well.
Yeah, I think training is going to be absolutely critical. I think we have an issue now in that once CMEs are not going to take care of the problem. So we're going to have to figure out some sort of systemic training because, people will talk about human in the loop. Well, if you're not trained to know what could go wrong in this system, then how are you going to function in the loop? But the system can also try to take care of some of its errors. We also need to develop ways to look for biases. I don't think we have a great sense of that. And and it's more complex certainly than what I even presented, because when we look at diabetes, there are different clinical recommendations based on patient race. I will let a different researcher talk about whether or not that's appropriate. But there are all of these variables that feed into these decisions that right now a clinician still has to try to weigh these things, and if they aren't prepared to do that, then that certainly can be a problem. And then in the future, they have to be able to look for the errors, and that's not something anyone is prepared to do yet. So I agree with you; it's going to be a huge lift, but if we're going to get there, it's going to happen. In XR, maybe. We'll see.
Thank you.